Good evening, professors and colleagues. First of all, I would like to thank Dr. Saad and the Mega Online Academy for giving me this privilege to be part of this session. The next presentation, titled Paediatric Emergencies, will be lectured by Professor Moataz Abdelrahman, Consultant Anaesthetist, Royal Manchester Children's Hospital, Manchester University Hospital Trust. Professor Moataz Abdelrahman is an eminent anaesthetist, not only in Egypt, but worldwide. It's a great chance for me to introduce Dr. Moataz and be a moderator for this session. اتفضل Dr. Moataz.
Thank you very much, Dr. Manal, for the introduction. And I would like to acknowledge and thank very much Professor Saad and the team he's working with for allowing us to actually get into this course, and for the effort which has been done. I could see all the lectures and all the speakers. It's a huge effort, and I would say I've not seen anything like that which is carrying on continuously, and I hope that stays and we can keep it up. Today we're going to talk about the emergencies in pediatric anesthesia, and to tackle this subject, I thought it's a really very difficult one, because what sort of emergency we would like to talk about? Would we like to talk about emergencies as in an APLS type scenario, advanced pediatric life support type scenario outside the OR, or would we like to talk about emergencies under pediatric anesthesia during anesthesia, or peri-anesthetic emergencies? So, and I tried actually to combine everything to give the audience as much information we can during this 40 minutes or half an hour. So if you talk about the emergencies, you need to specify what type of emergencies, and it comes down to either a seriously ill child or a seriously injured child. And that's the classification, the classic classification for, or from the APLS. The most important thing is that an anaesthetist, or one who actually deals with emergencies, need to have a structural approach. And then again, the classic approach for dealing with emergencies through the APLS would be a primary survey and a secondary survey. The primary, and then the primary survey we're going to go through, which is always to do with ABC, the famous ABC. I just put this slide to just give people a quick reminder about cardiac arrest in children. It's not essentially due to cardiac disease. So if it happens under anesthesia, there must be something happening, primarily hypoxia and hypoxemia, which causes to this. It does have a poor outcome unless it actually happened under anesthesia or peri-operatively, where he corrected the cause very quickly. So if you talk about cardiac arrest in general, when we say poor outcome, this is out of hospital cardiac arrest. In hospital cardiac arrest, and indeed in the OR cardiac arrest, and particularly if it was due to a cause in relation to anesthesia, you need to have a full hope that you're going to get this child back again. It's not like the out of hospital cardiac arrest where the outcome is very poor. In such circumstances, if you've got a cause and you try to correct it, you probably, in most cases, will get by. Needless to say that most cardiac arrests in children are due to asystole or pulseless electric activity, which means dehydration, hypovolemia, and such, and hypoxemia. Again, the structured approach, which is adopted by the APLS in managing such cases, and I actually like it, because at least if you have a framework in the back of your mind that you're actually talking about early assessment, immediate treatment, which is resuscitation, whether you are in the operating theater or whether you are in A&E, on a ward, outside hospital, just remember that you got to do an assessment, a quick assessment, resuscitation, which means immediate treatment, and then follow-up assessment. This is the secondary survey, and emergency treatment specific to the actual reason or cause of the illness. And then later on, when the patient is fine, late assessment and initiative definitive treatment if the reason is something to do with trauma or something to do with an infection or something like that. Later on, the medics or the surgeons can deal with this. And obviously, you need to refer the child to the appropriate clinical area if this was not in the emergency theater or in the operating theater. The classic APLS approach is ABCD: airway, breathing, circulation, disability, and exposure. Disability is basically neurology. You need to know how this patient is looking like from a neurology point of view, and exposure, so that we do not actually miss the rash and the fever. You need to look at the skin, whether you are in theater, operating theater, or actually outside. Don't miss the skin, because it gives you valuable information, and including fever as well. I think we talked about this: primary assessment, resuscitation; secondary assessment, emergency; diagnosis, and definitive management. This would be in the back of your head. The common scenarios or the common themes we do have, again, for all children, regardless where that is, it's either airway and breathing. And it's very important for the clinician, particularly I understand that there are quite a lot of trainees attending this session. It's of paramount importance that the clinician, particularly the anaesthetist, is very well skilled in the recognition of the potential respiratory failure or respiratory problem. And it comes down to either effort in breathing or efficacy of breathing. And you need to be able to suss out the stridor, look at the respiratory rate, and if it's quite high, that means pneumonia, recession, grunting, accessory muscle use, flaring of nostrils, and gasping. These are all signs of difficulty and labored breathing, which denotes you're dealing with a respiratory problem here. The efficacy of breathing, obviously, if you look at the chest expansion and the abdominal exertion, and it's actually deficient, and if you put your stethoscope on the chest and it's silent, then again, this is quite an eminent sign of respiratory failure, and obviously oxygen saturation. Quickly, again, the circulation, you've got the heart rate, the pulse, the capillary fill, the blood pressure, and I'm not going to dwell a lot into this, but remember, in children, we're talking about a heart rate between 70 and 220. Less than 70, you're talking about a failed pump here, because they depend on the heart rate more than anything else, and you need to start resuscitation if it goes 60 or below. Bradycardia 60 or below, and particularly infant and young children, and you need to start your resuscitation. You don't wait until you get a full cardiac arrest. We're not going to teach people how to actually gauge the pulse volume, but it's very important. One of the most important signs in children is the capillary fill time. And what you do is you press for 5 seconds on the sternum or on a digit, sometimes on the forehead, and some people do it that way. And then after the 5 seconds, you remove your finger, and the return of circulation should come back after 2 seconds. And it's a good sign of decent cardiac output if it's 2 seconds or less. Blood pressure, you need to remember that blood pressure, even in adults, is a late sign of shock. Children do have a very good way of actually maintaining their blood pressure till the end. Neurological assessment, the famous AVPO, if the child is alert, responsive to voice. The Glasgow Coma score scale here is probably needs to be modified, and we go by the AVPO so alert, respond to voice, responding only to pain is kind of a later sign of neurology, and non-responsive to all stimuli. Responds only to pain and unresponsive, that means you're heading for intubation and full resuscitation. You have to look at the pupil size, reaction, and dilatation and non-reactivity or inequality. The posture helps as well, whether it's hypotonia, decorticate, or decerebrate. And that's just a reminder of how do we assess, children under an emergency situation That applies to anaesthetist in anywhere, including the in theater. And remember the temperature, because it tells you about infection and sepsis, which is very, very serious in children, and convulsions, febrile convulsions, quite common in children, rash and bruising because of allergic reaction, septicemia, and infection with rash, obviously. Let's go into the meaty and important thing, and I hope that we've got some of the attendees, of our colleagues, who are now interacting with us. The first scenario, which would help and stimulate us to think about the emergencies, a 2-year-old child coming for circumcision.
Dr. Moataz, sorry for interruption. Do you want attendees share with you the discussion?
Yes,
now?
yes. I understand. Yeah, I understand that we've got 20 or 25 colleagues who are on with us.
Okay. You please, attendees, colleagues, you are allowed to ask questions and interact with Dr. Moataz in the upcoming scenarios.
I would ask you, Professor Manal, if you don't mind, if somebody actually writes an important question or something, because I can only see the presentation. I can't see my the comments. It's very difficult for me to see that. I will try actually, but I hope yeah.
I will inform you about the questions at the end of each scenario.
Okay, I try to get the question.
To not interrupt. Okay.
Right.
I see the question. 1 minute.
Okay, I've got Q&A questions here. Right, participants. I can see the participants here. Okay, but I can't see comments, so I'll just close the comments. I've got Q&A here. I can see the Q&A, but I would leave you to guide on the questions.
Okay.
And answers, yeah.
1 minute. 1 minute to open the Q&A. I have a problem to open them.
That's fine. Okay. I'll carry on with the presentation.
Okay.
Yeah?
Okay.
No problems. So the first case would be for a 2-year-old child coming for circumcision. That child had an inhalation induction. He had a 22 gauge cannula sighted into his hand. We tried a laryngeal mask size 1.5, which proved to be leaky. So we went to size 2. There was no leak and it was easy to ventilate. A penile block was performed by the registrar, and the child was taken from the anesthetic room to theatre. We use anesthetic rooms in the UK most of the times. Sometimes we don't use them, but most of the times we use them, hence from anesthetic room to theatre. In theatre, following the start of the procedure, please note the parameters down there. The saturation of this child went down from 99 to 89%. The heart rate went up from 116 to 142. Blood pressure is 92/64. The end-tidal CO2 was going at 25 millimeter. The chest, having listened to it, there was a bit of a bilateral diminished air entry. And trying to bag the child, it proved to be difficult to bag. Now comes the point where people can share. I'm not sure if they are there or not, but we need your thoughts about this. Can somebody tell me what would they think that could be? Is anybody with us? Professor Manal? I can't see Professor Manal though. Right.
Yeah, we are here. I think laryngospasm.
Who is saying that?
Anahita.
Right, you think laryngospasm. And why do we think it's laryngospasm? Can somebody else try to let us know? What can cause laryngospasm here? What's the issue? Why did this child, why do we think there is laryngospasm?
Dr. Saad, excuse me, I can't hear the questions. I have a problem to open the question, Dr. Saad.
Can you check the chat, please?
Chat. Okay. Okay, Dr. Moataz, Dr. Asma Badawi ask you
yeah, somebody mentioned LMA position, so that could be a malposition or disposition of the LMA, which I accept. That's good. I think it's due to laryngospasm. I had laryngospasm here, and the laryngospasm may be due to light anesthesia, as it happened with the start of surgical stimulation. Laryngospasm, anaphylaxis. Somebody said anaphylaxis, start ABC. Laryngospasm versus anaphylaxis, light inadequate anesthesia. I like all these answers. Positioning of the LMA would be my first thoughts, and we reposition the LMA. Still the same problem applies. Now I'm thinking of laryngospasm, which could give you bilateral diminished air entry. Somebody commented and said it's in the beginning of surgery. That is correct. It's the beginning of surgery. But again, in the beginning of surgery, they should be deep. But what we note here is that we've put a penile block, and we depended completely and solely on penile block for the circumcision. There is no opiates given. There's nothing else in terms of analgesia. So if we think down the route of laryngospasm, then what do we do? Who wants to volunteer? You can write or talk. I'm quite happy. I can see your answers here.
What's the question, Dr. Moataz, please?
Yeah, the question is on the screen. What to do? So I've got an interesting one, bronchospasm here as well, and aspiration. Thank you. Yeah. Aspiration as well. Thank you. Aspiration, malpositioned LMA, bronchospasm. Increase the depth of anesthesia. That's one. Okay.
Ketamine.
Remove LMA. Thank you. Ketamine. Thank you.
Ketamine.
Deepen the level of anesthesia. So ketamine, deepening the level of anesthesia are all things which we would like to do. Small dose of propofol. Thank you very much. That's excellent. Give 2 milligrams. Why specifically 2 milligrams? 1 to 3 if you want, but that's good. Deep anesthesia, if not reversed muscle relaxant. Okay, thank you very much. So how about high flow oxygen? 100% high flow oxygen. Yes, I would start straight away with this. By the way, during an emergency, you're not going to think about one thing and wait for another 2-3 minutes and do the other thing. No, high flow oxygen. Yeah. How about CPAP? Do we agree? You're actually symptomatically treating what you've got of desaturation and what you think is an upper airway obstruction or an airway obstruction generally. How about fentanyl? Is it good? It can work, but that will take us some time. We think that we're lacking analgesia, and some people will reach to a fentanyl or morphine to give it, which is a good and excellent analgesic, but maybe not an emergency situation or near emergency situation. Increase the inhalational concentration and give a small dose of propofol. And I'm not actually telling you anything. I've got all, thank you, Khalid Balla, all go simultaneously, Doctor. Excellent, definitely. Deflate the stomach, I like this as well. High positive airway pressure, excellent. That's very good. Yes, propofol 1 to 3 milligram per kilo. Increase the inhalational concentration, all go simultaneously. A muscle relaxant, if things don't go well, do you want to give a muscle relaxant? Yes. Which muscle relaxant? Anybody wants to volunteer? Yeah, straight away. Yeah. Anybody wants to type it? Yeah, muscle relaxant. Which muscle relaxant? Choice.
Succinylcholine.
Succinylcholine, succinylcholine. Anything else? Any other takers?
Rocuronium, suggestion. Rocuronium, succinylcholine. Rocuronium.
Atracurium. Right. Let's go around all this now. Right. Okay. So we've got sux, or succinylcholine, we've got rocuronium, we've got atracurium. Which is the best? I don't know which is the best. Rocuronium might be a good thing if you've got Sugammadex. Yes, give a dose, but you need to give a big dose for it to work quickly. If you want it to work quickly, you need to give a decent dose. Sux, this is the classic one. But remember something about Sux. What is it about Sux? If you give Sux in hypoxemia, you're risking bradycardia. But Sux is the gold standard up until now. So if you give succinylcholine or succinylcholine, then it is the gold standard. Somebody said bradycardia here. Excellent. I like that. I like that. Well done. So I myself, if I've got rocuronium, I would give a big dose of, or a decent dose of rocuronium, 1.2 milligram per kilo. You can actually intubate with 0.5 milligram per kilo, but you'll have to wait for more than 1 minute, maybe. If you intubate with 1.2 milligram per kilo, then you would be able to intubate with this if you're going to intubate. Some people give a small dose of succinylcholine, 1 milligram per kilo or 0.5 milligram per kilo, on the premise that hopefully it's not going to cause bradycardia and it will relax the cords for them to be able to still ventilate without intubation. Maybe that does work. But if I reach this stage, I would give a decent dose of rocuronium or a decent dose of succinylcholine, which is still the gold standard and classic. Well, somebody said low dose Sux preceded by atropine. Maybe I've got a little bit of a lag here. Thank you very much. I like that. Preceded by atropine. It would be expected from pediatric anesthetists to have on the table atropine and to have succinylcholine handy. And when I say handy, means some pediatric anesthetists do draw it up in a syringe, which I respect, or others keep it very near so that you can break the ampoule and draw it and give it. So the gold standard would be Sux, or if you have Sugammadex, you give rocuronium. Right. Anything else you can do? I'm going to actually, and obviously intubation or no intubation, it's up to you. You might actually give a small dose of Sux and some propofol. You break the spasm, you deepen the child, you tell the surgeon don't touch the child until you give a dose of opiate, morphine, if you don't have fentanyl, and then you go back again and do the whole thing. Or you intubate and forget all about it and get it going. The other way, is there anything else you can do? Oh, I've put this. What do you think about doxapram? Is there a rule for doxapram? There is a rule for doxapram, but maybe not in this situation. It will come. So that's laryngospasm, obviously. And remember doxapram. Okay. If you stimulate the larynx, you get glottic closure, airway obstruction, hypoxemia, bradycardia, low cardiac output, and cardiac arrest. And you want to avoid all this. What are the predisposing factors? Young age, upper respiratory tract infection. So children, and it's always a big debate whether we actually anesthetize children with upper respiratory tract infection or not. For elective procedures or for emergency procedures, you cannot do anything at all, obviously. But yeah, lignocaine, thank you. I'm going to come to this. Have I used laryngoscopy? I'm not sure if this poll relates to me. Yeah, okay. But that's fine. That's the next lecture. So the predisposing factors, I mean, upper respiratory tract infection, again, in the first week and up to the second week, you are very highly going to get some sort of laryngospasm. You decide to do it maybe after the second week because the airway clears after 6 weeks from the upper respiratory tract infection. Maybe you want to do it after the second week and you know that you might get a laryngospasm anticipated and you're going to manage it. Children with asthma or atopy, passive smoking in the family. If you're doing some airway surgery, it goes without saying, and somebody's actually put anesthesia for the airway, which is lignocaine. Yes, if you're doing airway surgery, and that's going to come as well. then you anesthetize the airway, and that's where the lignocaine comes into the equation. Somebody's asking about sublingual succinylmethonium in emergency. The answer is yes, but if I have a cannula in, then I would use it intravenously. Very recently, one of my colleagues used intramuscular. She was putting a patient off to sleep with through inhalation induction, and the child proved to be very difficult to ventilate. So she gave him a dose of intramuscular succinylmethonium. Yes, intralingual does work. The times I used intralingual one time because it's like an intravenous route. The intramuscular route works. It does take a little bit more than the 1 minute, the usual maybe 2 minutes or something like that, but it does work if you give a decent dose, 5 milligram per kilo or something like that. It does work as well intramuscularly if you're worried about anything to do with the tongue. Remember the predisposing factors as well. Secretions, blood, debris, edema of the airway, inadequate depth of anesthesia, endotracheal intubation, manipulation. If you actually manipulate the airway without giving a muscle relaxant in a semi-deep child, you risk a laryngospasm. And post-extubation or during extubation. Again, a colleague here is asking about dexamethasone. Of course, when you have something like that, you'll end up giving dexamethasone. But remember, dexamethasone is not going to immediately work and get you out of a laryngospasm. It's got a role to minimize the edema for afterwards. And yes, you probably want to give it. How do you prevent the whole thing? Do a good assessment, anticipate the risk. Never manipulate the airway during light anesthesia or the in-between stage. If you're just thinking, remember to manipulate the airway, you need to have the pupils small, very small, and you need to have the eyeball centralized. You open the eye, have a look at the eye of the child. You need to see the child looking at you, not looking down, not looking up. If they're looking down or looking up, that means they are not deep enough. So they need to be central, looking at you, and the pupil needs to be very small. Always maintain a clear airway through suction, removing foreign bodies, and what have you. And some people adopt fully awake extubation. If there is an indication to extubate deep, then it needs to be very deep extubation, which means extubation at a level of surgical anesthesia. Okay, we'll move on. And then anesthesia to the airway, which is obviously topical anesthesia or a block, if you really, but what it means here for the prevention, if you're going to do some work on the airway, you have to anesthetize the airway. There's no way you can just not anesthetize the airway and do your surgery. Scenario 2, very quickly. 6-year-old girl admitted late night with moderate to severe abdominal pain. The surgical team planned an appendectomy and possibly a laparotomy. And because she had been dehydrated and not fasted, the decision, I mean, she came late night, the decision was made to give her some fluids and take her to theater in the morning. She'd also been vomiting all the way through. She was taken to theater the following morning and had a GA. She did have a rapid sequence induction, and some people call it crash induction. We do cricoid pressure here in the UK. Some people don't, like in France. And she had thiopentone, succinylmethonium, sevoflurane, coamoxiclav, which is augmentin, fentanyl, and morphine. She was given all this. The surgeon started and noted and told you that this is a difficult and swollen appendix. And then you were asked to help in theater. You were not the anaesthetist at the time, but you were asked to come into theater to help because she was hypotensive despite the fluids she was given. She was given Hartmann solution 20 ml per kilo and a bolus of gilofusine 20 ml per kilo was ongoing. The heart rate 129, blood pressure 52, she's 6-year-old, 52 over 28, saturation 92, and your oxygen saturation was 80%, and the end tidal CO2 was 33 millimeter mercury. Yeah, What do we think? Anybody wants to volunteer? Oh, severe sepsis, that's good. How about the chest? I like that. Anaphylaxis, how about the chest? How about the chest? Septic shock, sepsis. So hypotension. And remember, we need to default back to our assessment, if you remember. Anything, even in the OR, and we're an anaesthetist and we can actually see everything very quickly, you need to go back to the assessment. And the colleague who's asked about the chest is very, very legitimate here, because obviously this picture could be sepsis, could be anaphylaxis, could be severe hemorrhage. Could it be? Yes, could be severe hemorrhage. Why not? Carcinoid syndrome and intussusception. Yes, intestinal obstruction can cause this. That's for sure. Right. So we're all here about assessment. So that's the chest. Bilateral wheeze all over. That answered a lot of your questions, didn't it? Again, difficult bag ventilation because the airway pressure is high. Look at that. Remember exposure, which we talked about. The colleagues who said sepsis is not wrong. Yes, this could be sepsis, particularly it's an intra-abdominal pathology and it's appendix and it's difficult and it's inflamed and it's infected and all this. Yes, indeed. You'd be really unlucky to have sepsis and wheeze as well, because sepsis might come with some bronchi and crepitations, but not necessarily wheeze. So hypotension and wheeze and rash on the chest goes more with, anybody wants to, hypovolemic shock, yes, I like that. Temperature was normal, thank you very much. Aspiration, pulmonary edema, anaphylaxis, electrolyte discharge should be corrected, especially with vomiting, thiopentone, morphine, antibiotic. Thank you very much. Somebody's trying to tell me that they've got thiopentone, morphine, and antibiotic. Yes, if you look at this, if we go back, she had thiopentone, she had succinylcholine, she had coamoxiclav, and what is that? What is that? So go back again. What is that? Gelofuscin, quite famous for causing allergy and anaphylaxis. So all the differential diagnosis was correct. I cannot disagree with anything. And presumably your immediate treatment would be what? Would be similar if it's sepsis or anaphylaxis. This was anaphylaxis, and here you are. And I refer you to this, which is the AAGBI, Association of Anaesthetists of Great Britain and Ireland guidance. And that's the latest and up-to-date one. You got the websites there. And that was 2019, the 2019 one. What do you do in this circumstance? Obviously, you've got hypotension and you've got bronchospasm. The one agent which is very helpful and do it all is adrenaline. Again, what's the dose of adrenaline? It depends. They teach non-anesthetists to give it intramuscularly. If you have an intravenous cannula, then I would give it intravenously. Yeah, and I would go 1 microgram per kilogram, 1 microgram per kilogram, and I would give this in titrated doses. Would I repeat it? Yes, I would keep repeating it, and if I stop it and there is hypotension, then I need to give it as an infusion, and that's the immediate treatment. Yeah. Later on, you can give hydrocortisone or chlorpheniramine. The dose is in front of you. Don't forget, which is very important, to do your tryptase test. So take one straight away and repeat it at 2 hours and then 24 hours. And if it comes positive, you know what your diagnosis is. If it doesn't come positive, still I would say it is anaphylactoid to any of these agents. I would send the patient later on for assessment and for testing, and I would tell the immunology specialist or the allergy specialist that this child has had these drugs and I would actually give them all. How about subcutaneous adrenaline? You're better off with IM, intramuscular adrenaline. You're better off. 1 microgram per milligram. I'm not sure, maybe he meant 1 microgram per kilogram. But yes, you're better off with the intravenous, followed by the intramuscular, because you will get it into the circulation better. And then maybe you know, I wouldn't think that the subcutaneous would be as effective as the intramuscular. But obviously, if you can't do but give it subcutaneous, give it subcutaneous, because in the community we give people something called EpiPen. I'm sure whoever works in the UK or Ireland will know about that. And they are actually advised, and the mothers are advised to give subcutaneous adrenaline, which they carry in their bag all the time. And the way they give it subcutaneous. But in theater, you've got an IV access. Just go for it straight away. Yeah. Remember, unexplained hypotension, unexplained bronchospasm, wheeze may be absent if severe. We have a silent chest, and unexplained tachycardia or bradycardia. You're heading towards the anaphylaxis. Give the adrenaline, even if it's sepsis, you're on the right path still. Are we okay with this? Right. I'm not sure about the time.
Actually, we're beyond the time now.
That's fine. I thought we've got up to past. It's 28 past now. So I'm happy to take any other questions later on. The other scenario was going to be for people to remember it very quickly. I've put the slide, and if you give me another minute, I'm not going to talk a lot about it. And that was a foreign body in the airway. Yeah. And the symptoms will be, you've been asked to see a 3-year-old in A&E with history of cough and some respiratory wheeze. On admission, there was respiratory distress with tachypnea, tracheal tug, subcostal indrawing, and working accessory muscles of respiration. The respiratory distress is settling now. The mother gave a history of him going blue, which means cyanosis, when she was feeding him a boiled egg, followed by the history as above. His saturation now is 98, but he needs half a liter of oxygen to maintain his saturation. I'm just going to, basically, this child will need an emergency bronchoscopy. The bronchoscopy, we do it, obviously. I've got very nice pictures and everything here. I'm not sure if we've got the time for it, but we don't give pre-medication. We go for inhalation induction. Some people go for intravenous induction. I like to go for a hybrid technique, which means I tackle the airway with a foreign body via sevoflurane, and I've got a cannula as well. And if I need, I will augment it with propofol. So I've got both worlds. So quickly I can deepen them if I need, and I keep it quite calm so that the child does not have any issues with with irritation and moving what do you call it, and moving a foreign body which was distal, which was proximal to a distal. I'll show you this video. I'm not sure if you can see this on the screen, but I will try to make it as big as I can. Yes. So basically, this child did have this in his larynx, and that was an egg shell crack. That was the cover of the egg when mom was giving him the egg. That went in and went into the airway, as you could see. And the way we did it is we went for a tubeless field. We put a nasopharyngeal tube short of the larynx, as you could see, and we got the surgeon to go in with their instruments through a tubeless field to pull out the egg shell of the airway to clear it. You need to give dexamethasone. You need to have adrenaline handy for nebulization. In recovery, your enemies are edema of the airway and blood and debris from what it was left. Dexamethasone, adrenaline nebulization will ease the edema and open the airway up for you. Thank you very much.
I have a comment from our senior colleague from Saudi Arabia, Professor Dawlatli, about Sugammadex. Before 3 years, it is off-label, and it is unclear using of Sugammadex before 3 years. He would like to pass this comment to everybody from his kind. Thank you, Professor Dawlatli, for your comment. All floors for you, Professor Mohammed. Thank you.
Thank you, Dr. Moataz, for this informative lecture and interesting topics.